All right. So is this all set? Okay. All right, so hi everyone, good afternoon. My name's Maddie Brown. I'm a senior here, and this summer I interned at Brigham and Women's Hospital in Boston, and I was working in their Division of Global Health Equity. And so this division really focuses on, where are the gaps in health around the world, and how do we understand those, and how do we prevent those. And so this division is made up of medical doctors as well as epidemiologists and research methods sort of scientists. And so this division is chiefed by Dr. Paul Farmer, who is a medical doctor and an anthropologist. He also founded the nonprofit Partners in Health. And so there's very close ties between these two organizations, as well as with Harvard Medical School and Harvard School of Public Health. So I got to see a lot of different perspectives on the issues that I was thinking about this summer, which is really cool. And so I'm going to let Dr. Farmer tell you a little bit more about the division's mission, because I think he says it best.
The mission of the division is to understand health disparities. Why do some people get sick while others remain well? Once sick, why are the courses of people's illness so very different? And also, at the same time, to address those disparities. And that has led us to dozens of countries across the world where we have engaged in long-term work, training, building local capacity, and then building facilities and conducting research.
And so the team that I worked with within the division was the tuberculosis transmission team. And so I'm going to tell you a little bit about the nitty-gritty of tuberculosis, just so you understand the context and why I think it's so important, and why I view it as a neglected issue of social injustice within itself. And so tuberculosis is a bacterial infection, primarily of the lungs, and it is spread throughout the air. So that means that people who are sick would cough, breathe, talk the bacteria into the air, and then other people can breathe it into their lungs. And so conditions that make it really easy to spread this disease are those of crowded, cramped areas with poor air ventilation. And so you think about public transportation, you think about people's homes where you live 20 people inside one room with one window. You think about hospitals that have people crammed in waiting rooms or hallways with no air ventilation, and these are really easy places to spread tuberculosis. And so those are also conditions we think of when we think of impoverished areas and impoverished healthcare systems. So that's why there's 10 million new cases of TB around the year every single year, but you don't hear about it in the US. We don't talk about tuberculosis anymore. We think about it as a disease of the past. And that's because we really only see it in the US in our prisons and in our homeless shelters. Similar conditions as those I talked about. But then beyond that, actually breathing in the bacteria, once it's inside your lungs, most people's immune systems can suppress it. But those people who have some sort of diminished immune system, they can't, and it will develop into a full-blown disease. And so when you are infected with TB, you don't necessarily experience any symptoms or illness, but if it develops into disease, you do. And so when people have HIV, if they're malnourished or have some sort of other chronic condition that make their immune systems weaker, that's when you see the actual illness. And so that's like fatigue, fever, extreme emaciation and weight loss, coughing up blood and sputum, and essentially you're deteriorating lung tissue, and it's really, really horrible disease. And so again, those are conditions that we associate with poverty, HIV, malnutrition. And also, you have to be diagnosed and treated effectively in order to prevent long-term consequences from this. And so healthcare systems that don't have these expensive diagnostic technologies like X-ray or microbacteria testing, those people may not be diagnosed correctly or treated effectively. And so there again, we see the consequences of poverty there. And so moving forward, you need to be treated effectively in order to not die from this illness. And so 1.6 million people around the world do die from this illness every single year. And so it's not a failure of the drugs. We have the drugs to treat tuberculosis. It is a curable disease, but it's a failure of our public health systems, and it's a failure of our health delivery around the world. And so these are in places where hospitals maybe don't have the resources to always keep their drugs stocked. Maybe the people in these communities, they live miles and miles and miles away from the nearest health facility, and so they don't see it as worth it to take their time out of making money for their family or taking care of their family to go restock their drugs. And so these are issues, again, that we see in impoverished communities. And so whether or not you can treat the disease effectively determines whether or not someone will live, and also determines whether or not they will develop drug resistance to the disease. And so a huge problem around the world right now is multi-drug resistant tuberculosis. That means the bacteria no longer responds to the antibiotics, and this has a really low survival rate. And so that, again, you have a higher risk of acquiring that multi-drug resistant TB if you are not having access to those medications. And then finally, so you can also spread multi-drug resistant TB to other people. And so we need to make sure that our infection control is really good in these settings of, like I said, public transportation, houses, and hospitals. And so this is what my team focused on, was this infection control piece of it, and how do we improve that, and how do we measure the effectiveness of infection control in healthcare facilities. And so basically the issue is that we have a lot of ways to prevent the spread of TB in healthcare facilities, whether that's through screening programs for patients, whether it's through ventilators for healthcare workers, or whether it's through some sort of sanitation system of the air. But we have actually no idea if this is making a difference in the spread of TB, whether people are getting sick from other people in hospitals. We actually don't know how to measure TB transmission. And so this is what we were working on over the summer, and what I was thinking about a lot was, how do we measure TB transmission itself? And so this is sort of the indicator that we were developing and we were evaluating over the course of the summer. And this is the risk of TB among healthcare workers relative to the general population. So essentially what this is saying is that healthcare workers are like canaries in a coal mine. So they tell you when the infection control is good or bad in a hospital. So because they're the ones that are there all the time, breathing the air, having contact with patients every day, they're the ones that, if the infection control is bad, they're at really high risk of actually getting the TB themselves. And so this indicator, we wanted to see if this was a good measure, and also whether, those healthcare worker screening programs that you would need to get the data on this, whether they're practical and whether we can implement them in low resource settings. And so I had a lot of different perspectives on looking at this throughout the summer. So we were based in Boston with Harvard Medical School and Harvard School of Public Health, and they have a very academic and theoretical perspective on this. And we basically talked to them and we said, what do you think about this indicator? And they said, oh, it's not good. That's not going to work. It's not statistically sufficient, basically. So they say you can't compare the general population to healthcare workers because there's different socioeconomic statuses. They're not comparable in terms of their background risk of getting TB in the community. And then they said, most of all, you can't measure TB disease as an indicator of infection control, because only about 10% of people actually develop TB disease from the infection. And that's, again, as I said, when you have a suppressed immune system or something like that. And so you would have to measure TB infection to measure infection control. But the diagnostics for infection are much, much more expensive than the diagnostics for disease. So it is a much more sensitive study, but much more expensive to do. And so they said, nope, it's not worth doing. Disease won't tell you anything. And then on the other side, we also went to a conference in the Philippines, and we got to speak with ministries of health officials from the 10 highest burden countries with MDR-TB, multi-drug resistant tuberculosis. And so they were people that were working very closely with implementing programs and infection control in their countries where TB is a huge concern for them, unlike here in the US. And so they also said, no, we can't do this, but for entirely different reasons. And they said they don't have the funding to do this. They are already strapped for resources, and this isn't something that they can prioritize over other things. They also said that they don't have the human resources to do it. So their healthcare workers are extremely overworked. They don't have the occupational health departments like we do here in the US. So they don't have those human resources to do it either. And then they also said they don't have the data collection methods. So they don't have electronic medical records that are robust enough to keep this data. They don't have the analysis tools to do the statistical analysis you would need to do this. And then they also said that they don't have, the healthcare workers wouldn't necessarily comply with the healthcare worker screening program. So they don't have the same laws that we do here in the US that say the healthcare workers have to get screened. And they also, TB is very highly stigmatized in a lot of parts of the world, and so because of its association with poverty and because of its association with HIV. And so people wouldn't necessarily want to get screened if they didn't have to, especially as a healthcare worker, they're afraid of losing their jobs. And so people won't comply with the screening, so it won't be good enough to get the data that you need. And so, both of these sides basically said, no, this won't work. But as I said before, for very different reasons. But my supervisor and I weren't convinced. We think that there is a way to compromise on this, because basically we see it as a very important issue, and we think that there has to be something that we can do better than we have now, which is no answer for if TB is being transmitted in hospitals. So there has to be some sort of in between. And so this is kind of what we were focusing on this summer. How is sort of the idea of implementation science, and that's sort of the in-between between the theoretical and the actual on-the-ground operations, is how do we implement programs effectively. And I actually saw this in some of the work that Dr. Mays, my mentor, assigned me over the summer. This is an article from a study actually on TB and how it spreads in Peru. And this is a very robust article on, or a study done, tracking patients in the community, tracking their contacts, a lot of data to collect, a lot of data to analyze, and obviously a very well thought out research study. But their biggest issue actually when they went to do the study was that patients weren't enrolling in it. And this was because they didn't trust the American researchers that were doing the study. And so once they saw the American researchers, interacting with the Peruvian doctors, having a good relationship with the doctors, having a good relationship with the patients, asking them how they were doing and how they were feeling that day and really actually getting to know them, that's when they trusted them enough to enroll into the study. And so this was a consequence or an obstacle that they didn't necessarily see ahead of time, but something that could have completely derailed their entire study that they put so much effort into on the theoretical end. And so I think that this is something that we have to start talking about, because this article actually mentioned it, which is one of the things that not all articles do, is mention those issues of implementation. And so I think that we have to start thinking about it, and that's something that I really took away from the summer, is how implementation science is a really critical part of our programming that we do in global health, and not just the theory behind it or the research methods, and not just the outcomes of a really cool intervention, but it's how do we implement things effectively, and how do we think through that ahead of time before those obstacles come up. And I think that talking about it and publishing things about it is the first kind of step to get people thinking ahead on what those obstacles might be. So I think that was one of my biggest takeaways from the summer, and definitely that tension between the two perspectives of academics and actual on-the-ground work, and so in global health. And so with that, I would like to say thank you to everyone who made this opportunity possible. Through the funding, I couldn't have done this without that funding, and had all of these really wonderful experiences that really informed my future career, I think. And these are just some images from when I was in the Philippines at the conference, and then also an image of Partners in Health, which is a nonprofit that I was working with, which is one of my favorite places in the world. And so that's their office. But yes, so thank you so much, and thanks for listening to my presentation.